Right. So I'm very pleased to introduce our second illustrious speaker today. Dr. Kirsch is Director of the National Center for Disaster Medicine and Public Health here at USIS. And so if you're connecting all the dots, that means he's my boss. He, though, comes to us with decades of experience in disaster planning, response, recovery work throughout the world. He was at Johns Hopkins for a lot of years and is another national expert that is here with you today. So again, please, jot down questions as he talks, ask questions, engage, and all right, take it away, Dr. Kirsch.
Greetings, everybody.
Hello, sir.
So I changed this talk up a bit. We're going to talk about disaster health and public health. But we're going to start a little bit more topical. I don't know if there's enough hands. Like Dan, I work in Haiti. I've kind of worked in a lot of disasters, both domestically and globally, for a long time. I worked at the University Hospital in Haiti, which also was where the 82nd Airborne was, so I worked closely with them. Disclaimer. This is what we're going to cover. I'm going to start with a little bit, like I said, more topical discussion, because there's a lot of stuff going on in the disaster world these days. You might notice the last couple of years has been some people will describe it as I guess I can't use that term, but certain politicians used it, a certain kind of show. It's been a mess. We've had the worst, literally since 2017, was the most expensive disaster year ever in recorded history. 2018 looks like it's going to break that. This is worldwide figures as well as U.S. figures. This is an example of the trending disasters in our global setting in the last, like 25, 30 years. You'll notice there's a steady upward climb, which a lot of people would say is evidence of climate change, since most of these are climate-related disasters. They're flooding and hurricanes for the most part. Other people say that's not true. All we know is that it's getting really bad, really fast, and costing us a fortune. Last year alone, the U.S. government had to give a supplemental of $89.3 billion just to help cover the 4 hurricanes that occurred in the U.S., which is the most we've ever spent on supplementals, and it simply goes to add to our deficit because that's not accounted for in the regular budget. So 2018 has been really bad. We've had, across the world, there's been 7 major hurricanes that have affected really all parts of the world. A number of the South Pacific people aren't familiar with. A couple that brushed the U.S. and caused some damage. Matthew, I guess you heard about, which hit the panhandle of Florida. The wildfires in California and really across the country have been remarkably devastating and extremely costly. The most expensive and most deadly wildfire in more than 100 years occurred in the Car Fire that burned the town of Paradise. And this is that fire. This is the one that no one notices. There's a huge Ebola epidemic going on right now.
Yeah.
In the Congo. Second largest Ebola epidemic ever. So I want to talk about that because this is an example. All 3 of those disasters, each of those is climate related. The flooding and the hurricanes, the wildfires, and the increasing impact of emerging infectious diseases. And so this Ebola epidemic is really bad, and we've been kind of ignoring that. This is from Liberia in 2014, when I worked there on that epidemic, which killed 13,000 people. Essentially shut down the functioning governments of 3 different countries. And the DoD played a huge role in Liberia in particular, providing logistical support and building treatment. So, emerging infectious diseases, yeah. Ebola is one that's very scary because the mortality rate's so bad and it's horrible to die and all those things. The mortality rate is probably around 50%. With good treatment, it may go down as low as 30 or even 25% for some of the newer treatments we have. But it's bad. The nice thing about Ebola, it's really hard to get. You have to come in direct contact with body fluids. So the real bad pathogens are going to be the ones that are airborne spread. That's the ones that are going to kill not 13,000 people in West Africa, but tens of millions of people around the world, or hundreds of millions, or maybe a couple billion, depending on the pathogen. So Ebola, although we put a lot of effort into controlling it, we're very concerned about it because of the nature of the disease. It's not as bad as the bad case scenario that we talk about in plan for a disaster. So the Ebola epidemic in, well, this is a summary of the West African outbreaks. I won't go into details because they cover those. These are the countries involved. The U.S. was heavily involved. When the outbreak started, the world divided up the countries into theaters of operation, basically. Liberia, because we have a long-term relationship with Liberia, the U.S. government, because it was founded by repatriated slaves. We had Liberia support. The Brits did Sierra Leone, and Guinea was a combination of Brits and I think the French. I'm not sure. This outbreak spread out over the course of approximately a year. There was an early crescendo of cases we got all concerned about. It went away, came back in the fall at about the same time that the Ebola epidemic has started in Congo. The one in Congo started on August 1st of this year. And over the course between, in this case, it was really July through its peak in early November. Like I said, killed 13,000. These are the cases and the deaths. But let's turn to the Congo outbreak. So the Congo outbreak was the usual outbreak. Ebola comes from the Ebola River in the Congo, and that's where the first cases were found. That one is here. And so it's normal in this country, normal per se, to have outbreaks of Ebola. There's been 16 outbreaks of Ebola in this country in the last 30 or 40 years, which account for about 70% of the Ebola throughout. However, the difference is that the Ebola outbreaks usually occur up here, and in this case they're occurring over here. So it's a little bit different. The unique thing about the West African one is this is where Ebola usually occurs, and it occurred over here. And that was why early on in that outbreak, people didn't believe it was Ebola. People thought that they were being lied to by the government. They thought it was a conspiracy. They thought all kinds of stuff. Because it's almost 2,000 miles away from where Ebola is supposed to happen. We still don't have a good explanation as to why it jumped into this population of bats and monkeys, but it did. But that's not necessarily a good sign because the virus now is moving throughout this belt of Africa. It's not isolated to this very rural area here where it's supposed to go. So when we start trying to intervene in an epidemic, there's certain indicators that we use to determine whether or not we're winning. We have, since August, the world spent hundreds of millions of dollars intervening in this epidemic. The U.S. government alone has spent $20,400,000 and has budgeted another $5 million for the rest of this fiscal year, or for the rest of this calendar year. So this is what the situation was in, this is the new one, right? We'll move forward here. Well, this is what the situation was a week ago, or 2 weeks ago. The situation that you have in your hand is the last report that just came out yesterday, I believe. And you can see that at 2 weeks ago, I guess it's only a week ago, there are 471 confirmed cases, total cases, which they count 423 confirmed, and the rest probable cases. And about half those people died, a little over half the people died. We know, particularly from the Liberian outbreak, but from all outbreaks, that this number may represent a tenth of the real cases, a quarter. It's like way undercounted. A half would be lovely if that's all it represents. But we know it's much worse than that. We look at, so one of the things we look at to measure whether or not, after now the world has been intervening into this situation for 4 months. We've spent hundreds of millions of dollars. And so these are the things that we like to look at to say if we're winning. The obvious number is, are there new cases occurring? That's a really good indicator for they're winning. There's more subtle ones though, and one of the most subtle ones is what percent of new cases occurring do we know about in advance? Because what we do is when there's a case, when you get Ebola, we go to all your friends and family, and we follow them. And we make sure that you know, when they get symptoms, someone gets symptoms, we can intervene right away. Nowadays, there's a vaccine, we give them vaccines. So when we have cases that occur that are not on our list of people we're following, that's really bad. Because that means it's all over the place. So on this date, there were, if we go to the next slide, there were, from about 5 weeks before, more than double the number of cases. 55% of the new cases identified in this period were untraced cases. That means there's cases all over the place. We have no idea where these cases are coming from. Other things we like to look at is the geographic spread of the disease. If we're containing it in a single area, that's great because we can do ring vaccinations now, we can do tracing of just those areas. It provides all kinds of ways to be better at doing this stuff. This is what the difference has been in the course of that time. It's spreading, the disease is spreading in these areas. Why is it spreading in these areas? Because these are areas, the green striped areas, are areas of armed conflict. There are a number of rebel groups that have been existing in that area, in that environment for 30 years. They're not only fighting, but as you can see, the armed conflict areas are spreading. The groups that are fighting are using the destruction of Ebola to spread their theater of operations. And as a result, the disease is spreading. Now, if you look at your handouts from the most recent, it's even worse. From just this 1 week period, from here to the one that you have in your hands, 50-some% of the new cases are still untraced. There are new cases occurring, and these are divided into, I think, 14 districts. There's new cases that have been identified in 11 of the 14 districts. And there's a new district, 2 new districts that are involved. And 2 of the districts where they thought they controlled the disease, where there hadn't been any reported cases for more than 30 days, had a recurrence of cases. So all of this information tells us that we have got no idea what's going on with this. That's a real problem. There are cities, Bunia is one of them, which has almost 1 million people in it, and it isn't access to trains and plane flights. There are other cities that aren't on this map that have more than 1 million people that are in the area. Should those people get on planes and trains, it's going to be a real problem. It's going to get spread over everywhere. This is a big problem. This is the future of disasters. The future of disasters is not that we just have a disaster, but they occur in countries like Haiti, where there's effectively no working government. So they occur in situations where there is little social or political infrastructure to allow us to adequately intervene in those disasters. And this is a good example. This is chaos. This is ongoing civil war and bandits for 30 years now, and we have an Ebola epidemic. So how do you respond? Because like Haiti, because like a number of disasters we've had recently, it's not just a disaster anymore, it's a security problem also. And this is where the DoD plays an increasingly large role as a result. The issue here is that the US government, unlike with the Liberian outbreak, where we made a very specific commitment to provide not so much security, but logistics at least, and to use our military to engage, had a big role. Whereas in this case, the US government has refused to send anyone there, including CDC people. They won't even let the CDC go into the area to do their usual interventions that they do because of the security issues, because of the politics. The old government thought it was good to intervene, this government doesn't think it's good to intervene. Those issues are going to drive disasters forward. Those issues are going to drive the DoD and your role in those disasters forward. We in Haiti, or in Haiti and Liberia, and in Haiti, the military did not provide health care. They were not involved in health care. They refused to provide health care. They did the security and logistics for the most part. When they built the ETUs, they didn't step into them. They used public health service people and volunteers and NGOs to do them. In the future, will the DoD decide to cross that line too? I don't know. It's a big policy issue that will occur in your lifetime, in your careers in the military. These policies are going to go forward. So is it worth risking our troops going in an infectious environment, which then could spread among our units? I don't have an answer to that question. But these are the questions that are going to be coming up for you guys going forward. And I think very important questions. Because as you can see from that graph, it's just going to get worse. There's just no question about it. It's going to get worse. The more disasters occur, the more likely they are to occur in marginal economic countries. The more likely they're going to require external aid from the US and from other rich countries. And so there's going to be all of these questions going forward that you guys are going to have to address. So you need to keep this in mind. To me, it's a very interesting topic. To me, this is really scary. Unless something happens. The only reason this hasn't gone everywhere is because we have that vaccine, most people think, and we've been able to vaccinate a number of people. They're now making the decision that they're going to start, so even in Haiti, or in Liberia, early on in the event, healthcare workers died like flies. Nurses in particular. The mortality rate among nurses was like 60–70% in the early outbreaks. And as a result, the entire healthcare system collapsed, because who's going to go to work? So all the hospitals closed, all the clinics closed, everything closed. There was nothing there. So one of the early things that we did in Liberia is we protected healthcare workers by providing them PPE and training and by doing all kinds of things. And the first treatment unit built by the US government, by the military, was a treatment unit specifically to care for sick healthcare workers. Because we wanted to reassure people that they weren't going to kill themselves by providing care so that they could be on the ground.
Yeah, I said it was somewhat dysfunctional, as you know, healthcare system before Ebola. They only had a couple hundred doctors, and yeah, it was scant in the beginning.
And Haiti had the healthcare system. So these are our issues that are important. So they're going to start vaccinating healthcare workers in all the surrounding countries because they're concerned that when it does leave the borders, those healthcare systems will collapse. And so that decision was made just in the last week. That they're going to really target their vaccinations less on the ring vaccinations for cases because there's so many cases, and more on healthcare workers because we know healthcare facilities are transmission points. So disasters. Now we're going to go back to the regulatory. Any questions or comments on the Kimchi's about to hit the fan lecture?
And speaking of those, the Ebola treatment units in Liberia, my previous unit, we sent lab techs down to respond. And deploying in theaters of operations where there are infectious disease outbreaks, we currently have a HADR training mission, continuing promise mission, and that routinely goes to Central and South America. And 2015, tail end of like the Chick V outbreak down there, and right before the what's the other big one? Zika virus. Yeah. So right before, so we're at least Navy-wide, we're continuously in areas of operations.
Yeah. The Navy labs in Liberia were tremendous. So I did a big study I published, and we looked at all the interventions in Liberia and what worked, and building the ETUs didn't work, by the way. Wasted a lot of money. The labs probably made a huge difference. The labs and the burial teams that we funded for the most part were probably what made the biggest difference. And then community education, of course. But the Navy lab, there was one at the island ETU in Monrovia that was a very useful. So the Navy did allow some potential exposure for their people. The other services. So disasters, this is 9/11 obviously. What is a disaster? These are kind of parameters. You've probably heard all this stuff, so I'm not going to go into
We just talk about definitions of disaster a lot because, as you know, a lot of people speak about it differently. Yeah.
So it has to affect people and it has to overwhelm someone. You have to have outside aid. Those are the two major issues. What is disaster medicine? Good question. I don't think anyone's defined that. That includes me. It's medicine that's different. Dan talked about a lot about his stuff about altered standards of care or crisis standards of care or whatever the current politically appropriate term is. It's delivery of services when you don't have as much stuff as you usually have. So you have to be creative. So it's beyond mass casualty for the most part. Because disasters over there are mass casualty. When you have 20 injured or whatever, it's pain. It's hard. You get past it. Versus when you have in Haiti 300,000 injured. There's scales of difference that make quite a bit of difference. But the bottom line is that when we provide health care, whether in the military or whether anywhere else in our rich society, there is no concern about resources. You do everything for your patient. That's my ethical needs. I do what's best for you. And that means I'll order 400 MRIs and I'll start with diabetes and I'll put you in the ICU for 6 days and I'll spend hundreds of thousands of dollars trying to save you. There is no question of resources versus needs. In disasters, it's all about resources versus needs. And that's what the whole ethical dilemma is, that you have to make those decisions. And that may be as simple in a mass casualty firefight where you have to make a decision to let someone die because you have 3 people shot with chest wounds and you only got enough resources for 2. Or you have to decide to provide, should we take care of the kids or the old people? It gets a lot more complicated, and Dan talked about that. But it's a resources versus needs things. And that's why The most important thing in disaster response, whether it's for healthcare, public health, communications, anything, is moving crap. Logistics is the key. That's what fixes the problem eventually, is logistics. And so the role that the U.S. military has spent in logistics in a lot of recent events has been critical, because it's all about resources and needs, and the more resources you get in there, the faster you win. And with the trouble with healthcare is that it's time limited. As you all know, when you have an injury, there's the golden hour, or whatever you want to call it, you're going to be dead in a couple days unless something happens, if you have a significant injury. And so there's a very specific time limit for healthcare versus, okay, we don't have electricity for 5 days, versus, we don't have saline for 5 days. There's a big difference in regards to direct mortality. So there's the direct impacts that we talk about. Oops. And these are the things that we like to do when you swoop in, you have the stuff, and stuff. But it's really the indirect impacts we know that have the biggest deal. Yes, a lot of people got crushed to death in Haiti. They were going to die anyway. Probably more people died because they didn't have clean water, they didn't have electricity, they didn't have long-term health care. In Liberia, clearly, there are people who estimate that because the healthcare system collapsed in Liberia, there were more people that died from thyroid disease, malaria, childbirth outcomes, etc., than actually died from Ebola. And I think that's probably true. So it's really the loss of the infrastructure that in the long term causes loss. The best example of that is Hurricane Maria that hit Puerto Rico. The official number from the Puerto Rican government of deaths related to Hurricane Maria was 64. Those are the people who drowned in the floods or crashed their car into the tree during high winds, or their roof fell on them, or whatever. There have now been 3 different studies by 3 different groups, one from Harvard, one from Yale, and one from GW, that estimate the indirect deaths, the deaths that occurred that shouldn't have happened, range somewhere, well, the Harvard study showed up to 6,000. The 2 other studies were closer to 3,000. The GW study, which I think the methodology is best, was 2,970 excess deaths in 6 months after. 200 times that of the, 400 times that of the direct deaths. So we know that, and 54, according to the Harvard study, 54% of those were due to lack of access to health care. So there were about 1,500 dead that died because of the hurricane, because they couldn't get to a doctor or hospital. That's a lot. In Katrina, it was probably the same. We didn't do those studies, but we lost 29 out of 31 hospitals in New Orleans during Katrina. Most of them never reopened. So that there was probably excess deaths in continental U.S. also to that level that we just never measured. So it's really these structural impacts that have the biggest deal on health. And I'm going to race through a lot of this stuff because I don't have a lot of time. So we're going to talk about some of the specific disasters. We're going to talk about the public health, physical health, but I'm going to totally skip mental health because I know nothing about it except that I give people hugs after disasters to make them feel better. This is a civilian field hospital that was set up by a bunch of people from Baton Rouge in the floor of the Pete Maribit Center on LSU. Without any federal government help. Now this is after the feds arrived, so they have a lot more toys. But local responders all got together, people from Katrina, some of the doctors and nurses who had evacuated, and they opened a field hospital on their own in this center, this athletic center. I thought that was pretty impressive. So let's talk about public health. So I'm a physician, I'm an emergency physician. I practice emergency medicine at GW right now. But I also have an MPH, and I've done public health research and teaching all my life. So I'm a little biased, I have to state my bias up front. But I, except for the response to Haiti, have always done public health disasters. Because I personally believe that makes a much bigger difference. It's more fun to go in the tents and work and be cool, and feel better about it, although you're exhausted, it's unpleasant. But I really believe that what really makes a difference is the public health interventions. And so I've always worked in that space. Oh, these are, if you've never seen these are the UN flies these big water bladders into every big disaster, and that's how people clean water. So we're going to talk about these categories: food, shelter, water, communicable diseases, etc. And I'm going to breeze through them for the most part. Food, shelter, water. So So what's most important, food, shelter, or water? You're the guy who has to make the decision on what you're gonna put on that first seaweed bird.
Water.
Maybe. Why? That's what we thought in Haiti, and we flew in boatloads, millions of bottles of water to Haiti.
Because if you have access to, so usually your sewer systems overflow, your normal water sources are either not functional or contaminated. People drinking unsanitary water will die. Now that cholera has gotten to Haiti, cholera, the diarrheal diseases will take out a tremendous portion of the population that's left because their immune systems are already down.
So that's the theory, and that's why we literally fill T-130s full of bottled water.
Also, it's usually in tropical countries where it's hot.
But, so there's the other one. What happens if you're in Yerevan and you have an earthquake in Armenia and it's -6? What's the most important?
Shelter.
Yeah. And so everyone can wait for food, right? The interesting thing, particularly that we found out in Haiti, is we flew all this water. We were bumping medical teams off and we were putting loads, just planes of water, nothing else. And they were throwing it out and they had water everywhere. It was useless because in Haiti, the entire population, because they basically had no government services, was used to getting their water all the time. It made no difference that whatever few pumping stations that were broke, because they were used to looking for alternative sources of water. It was part of their normal social construct. And so we wasted a lot of time and energy and money bringing water to Haiti. We probably should have brought more health supplies first because there's so many people dying from that. So there's no magic answer on this. It's different with every setting. In Yerevan, after the earthquake in Armenia, we had to get shelter there. People, not only were they trapped in the rubble and freezing to death, but all those people lost their houses. And if you've ever been in an earthquake, you don't go back into buildings because you just watched all your friends die. So no one, after an earthquake, goes back into buildings. When we were in Haiti, I was at a meeting. We were sitting around with all the Haitians, and there were all these foreigners sitting there, and we're talking, and there was a little tremor. And the foreigners and myself are stupid, and we're like, did a truck just go by? And by the time we had to think of, did a truck just go by? The Haitians had all left the room. They were gone, and we were all sitting there going, what? Oh, okay. That was kind of dumb. Because you don't go back in buildings after an earthquake. I promise you, you don't do that, because that's how you die, and everyone understands that. So shelter may be important. And so when you make those decisions, if you're on the teams that are making those decisions, you have to bring those factors into account. There's no magic answer to that specific question. These are just shelters. This is an American Red Cross shelter. After one of the California wildfires, but from 2011, from a few years ago. And so the irony of this shelter is that you guys, have you heard about the SPEAR standards yet? Did you guys go over that? Have you taken Paul Reed's course? So there's been these international standards that have been established by the UN and multiple governments and signed off as being what we're supposed to do in a humanitarian response. There's liters of water per day per person, there's medications to be available for 100 people, there's space for everything, privacy, tents, all this stuff. We totally violate that in the US because this would never pass the same standards that get applied like in Nigeria. Because there's not a room and there's no privacy and there's not family units.
Is that 3 cots put together to make a queen size bed?
These are those blow-up beds.
Yeah.
If you ever get a chance, and you might get a chance doing HADR stuff to go in shelters, they're quite entertaining. They're getting better, but they're fascinating places to be. I've been around with the Red Cross a lot. I've slept on a lot of shelters, and they're always like this. And then people and I don't have the pictures, but we lay out these beautiful shelter rows, and within like 48 hours, everyone's like moved all the beds together, and they've created their family units, and they put up blankets, and it's total chaos. So this is an example of a good camp. This is in Bukavu after the cholera epidemic, after the Rwanda genocide. All the Tutsis fled. They came to camps. They moved into camps, and then there was a cholera epidemic that killed another. Besides the 500,000 were chopped to death by their fellow countrymen, another 30,000 died within 2 weeks of the cholera epidemic. Not in this camp. This is a good camp. So this is a well-sited camp. You'll notice the water's down here. They have latrines that are set away. I don't have the latrines on this. But this is a pretty well-sited camp with drainage and stuff. And we're getting better at building those things. So shelter's important. This is an NGO just literally came by, they found this group of people, and they just threw these tarps off the back of a truck and drove off. And as a result, you kind of get these randomly built structures. And this is an example of how not to do shelter. This is what Haiti was like afterwards, when people built their own shelters using their own sheets and bedding and stuff. So I referenced this earlier. This is the fancy, this is what it looks like. And you'll see, so these are more modern. This is Harvey. People are already starting to break the nice rows of cots into their family units. And this is what it looks like after a couple of days. Because people want to be with their friends and family, right? I mean, you want to have your own sense of privacy. So. Water and sanitation. The sphere standards, I don't need to go into details. There's very specific standards that we set. The goal initially is to get in as much water as you can. It does not have to be safe water, just water, the safest as you can have it. Then to eventually, as quickly as possible, move to fully certified drinking water. The bigger thing, of course, is poop. When you gather 10,000 people together in a relatively small space with dirt, poop's a huge issue. We don't need to go into the details of that, but that's probably a bigger issue than the water. And then the issue of sanitation that goes with that with hand cleaning and stuff like that. Communicable disease control. By the way, this is Haiti after the earthquake. And this is this picture demonstrates why Haiti was so difficult. These are so in Haiti, 46 families own 90% of the land of the country or something like that. So most people are forced to live in squatting places, and they build their own houses out of random bricks and blocks and other stuff on illegal land. As a result, there's no services, there's no electricity, water, anything. There's no roads. And there's barely paths that go along the different areas to get to see house to house to house. It's built on top of each other. So doing search and rescue and logistics is impossible in a country like that. That's not unusual for a lot of countries around the world. So, infectious diseases, everyone thinks that after disasters, there's going to be some outbreak of horrible diseases. And this was after Katrina, and I use this because these are high government officials and smart people making statements that are so appallingly whacked out in public forums that it boggles my mind. So in Katrina, in New Orleans, in America, where we don't have cholera or typhoid, the head of Health and Human Services to a press conference said, "We're very concerned that cholera and typhoid is just going to spring up spontaneously in the environment, or are we going to purposefully import people who have cholera and let them wander in the streets?" Like, are you serious? People say things all the time like dead bodies are going to cause diseases. Dead bodies, like if you have Ebola, that's how most people got their disease, caring for the dead, because their body fluids are infected. Dead bodies don't cause disease except with Ebola, and certain infectious diseases, cholera too, the dead tend to be, because they're covered with shit, and that's where the infection occurs. But unless it's like The Walking Dead, dead bodies don't cause disease. They don't transmit anything. And so to make statements which you hear after every disaster, someone's going to say that. It's not true. Dysentery, cholera, dysentery, etc. There is this constant sense of misinformation that there's going to be outbreaks of diseases. There are not outbreaks of diseases. It's different when you build camps because there's and because there's respiratory illnesses. And so things like measles and just general respiratory illnesses, pneumonia, certainly increase when you cause crowds. That's why we don't like building camps. We try to avoid building camps. But for the most part, after disasters, there aren't more infectious diseases. Now, in certain countries where malaria is endemic, there's a lot of standing water. We often see increased cases of malaria because there's no malaria control going on, and there's increased standing water, and there's better mosquito propagation. But for the most part, it just isn't a big concern. Okay, so you're all doctors. What does this person have? What's your diagnosis? So do your examination. So what are you seeing? You see he's skinny. His eyes are sunken.
Diarrhea.
Lips are kind of retracted.
Dehydration.
Dehydration. That's nice.
Diarrhea.
That's what I spilled on. This is severe dehydration. That's what I meant. His lips are dry. His eyes are sunken. This is cholera. This guy had cholera. But this is severe dehydration. You'll be seeing this around, so keep it in mind. Infectious disease, Congo, measles. So one of the things that we did do in developing the world in outbreaks, and if the anti-vaxxers in the U.S. keep it up and keep having measles outbreaks, we'll probably do the same thing in the U.S., is we mass vaccinate everybody when we bring them together for measles. Because high mortality, particularly with people who are nutritionally malnourished, etc., and people have other illnesses. And so we do mass vaccinations of measles. We're now, this Ebola thing is unique, because we're now using this vaccine, which is more or less approved by the FDA, but not really. But it probably works, because we did studies on it in Liberia, although we didn't get a great end, because by the time we started, it was late for. So we're now using that as an intervention. So that's kind of a unique thing going forward for the future. And maybe a model for all the, biodefense stuff that we're concerned about. A lot of things. It is a model. We have stockpiles of certain vaccines. Waiting. Dengue, malaria, I just mentioned immunization. I just mentioned measles, so we'll kind of skip through this. Except, what does this guy have? So, the thing that sets you off is you see a weeping eye, ignore that. What are your other physical findings?
Ptosis.
He has an asymmetric face and ptosis. This is tetanus. This is acute tetanus, that's tetanus. And that rictus, that torpid mouth is one of those common features. He was dead in there was a lot of tetanus after he. Dead bodies, we talked about that. Let's skip it. Let's move to some. We're going to skip mental health. And we're going to move to some of the more important things. There's only 10 minutes left. I mentioned that the biggest thing. Right, 10 minutes? The biggest thing is the loss of infrastructure. We know that. I've done studies all around the world on the impact of earthquakes on hospitals and water systems. And it's the loss of those facilities that is the biggest impact. Not only when we have an earthquake or we have an event that affects a healthcare structure, not only can't you care for the new cases, you have all the inpatient cases already there that you have to care for. So the infrastructure issue is a big deal. There's a big movement now in the federal government led by the Assistant Secretary of Preparedness and Response at Health and Human Services to prepare our regional healthcare systems better, because we're really beginning to understand this. If there's an earthquake in New Madrid in St. Louis and it takes out 2/3 of the hospitals, the average hospital in America nowadays runs at 95% capacity. The average ICUs in America run at over 100% capacity. So if you take out 2/3 of the hospitals and you dump all those ICU patients onto the market, there's nowhere for them to go. In Hurricane Sandy that occurred in New York City, we had to evacuate 7 hospitals within 24 hours. Who was hardest to place? What category of patient do you think was most difficult to place? But you got
The elderly and patient people.
elderly?
ICU.
ICUs are tough. There's certain ICUs that are tougher than others.
Oh, NICUs.
NICUs, man, there are no peds beds in this country. The worst of all patients, psychiatric. To the point where Bellevue Hospital in New York City has the only psychiatric ward for the criminally insane, the mass murderers and all those kind of guys. Try policing those people. That was a real problem. Because no one. This guy's only killed 13 people and he's actively psychotic. Do you want him to be?
But at the same time, there's a problem of the hospitals. If they don't run at that capacity, they can't maintain themselves.
Absolutely. Right. We have a unique problem in the U.S. because our hospital systems are private. In other countries, they can run 20% open beds. In the VA, maybe on purpose, maybe not, runs about 10 to 20% open beds. Part of that is the VA is supposed to be a backup residual thing for our hospitals. It's not well integrated, let me tell you, but it's being worked on. Same with some of the DoD facilities. They're not at 100%. So the thoughts are we're going to transfer all these patients. The truth of the matter is we're working now with Walter Reed, and we're trying to get them a trauma center status, but also let civilians into their hospital. Every civilian that you admit to a DoD hospital, the Secretary of Defense has to sign off personally to allow that person to have care in a military facility. For every civilian. That's the current policy. So those things have to change. And they'll change. So that's a big deal. Let's talk just briefly about some of the acute problems, then we'll go from there. This is a military field hospital in Chile after the earthquake. They had quite a nice system. Set up in less than 23 hours of fully operating in person. Very impressive. So this is me working with the 82nd Airborne. I always like to say the best thing I did in Haiti is I was a perfect IV player. And I stole so much crap, you can't believe it. For my patients, not for me. That was my main job. I was radar around. I went around and stole everything. So when we plan for disasters, we know what they do. So as healthcare workers, what do we care about? Do we care about the dead? No, they're dead. Healthcare patients. We care about the injured and sick. And so certain disasters we know are worse. So severe injuries, in hurricanes, floods, wildfires, you're either drowned or burned to death, or you're not. There's really relatively few injuries in those events, dead or not. In high winds, like tornadoes in particular, yeah, they cause a lot of injuries, but you know what, tornadoes are relatively small. And even the bad ones, like the big, huge tornado outbreak that 18 tornadoes a couple of years ago through Alabama and Georgia, killed 221 people and injured around 400, over an area of more than 1,000 square miles. So each individual facility, you know, it was like a mass casualty event. It wasn't really a big disaster. So it's really the earthquakes, because they injure a lot of people. The ratio, we always say, we say, and we're wrong, but we say it anyway. The ratio of dead and injured is 1 to 3. It varies from 1 to 1 to 20 from the studies that have done. You might say 1 to 3. But it's a lot. In Haiti, it was estimated 300,000 injured. Can you imagine taking care of that with a non-existent healthcare system? So when it comes to, the other thing we care about is the impact on the healthcare system. Earthquakes destroy hospitals. We know that. And even if they don't destroy hospitals, let's just say this is hospital. And we're standing here. And I'm giving you a lecture on renal failure. And it starts shaking. What's the first thing that's going to happen in this room?
The ceiling tiles are going to fall down.
All those ceiling tiles are going to fall on your head. And when ceiling tiles fall on people's head, they'll run outside the building. And we've seen that in hospital across the world. Hospitals may be perfectly fine, but when you have ceiling tiles sitting you on the head, everyone, including the patients, run out of the building. It's just the way it works. And then they won't go back to the building. After the earthquake in Mexico that occurred in 2010, the nurses refused to go back in the building for months because they didn't believe the engineers when they told them to say. Because no one wants to get crushed in that place. And so even if your hospital isn't damaged, the chance of your hospital working in a hurricane is really small that it's actually going to be functional, at least for a number of hours, if not a number of days, until the full engineering occurs. That's a real problem. And so earthquakes are bad, as a result. As you can see. The rest of them, not so bad. Katrina was different in that Katrina wasn't really a hurricane. The city was destroyed because the levees failed and flooded the city, which killed everyone. It wasn't a typical hurricane. Typical hurricanes, we evacuate hospitals for 24 hours, we got to go back, and what's happening? Life's good. Katrina was different because it was a flood that put hospitals underwater for days. So the other things we care about is the man-made stuff, and all the man-made stuff are bad when it comes to healthcare. You just got to keep that in mind. And I think I'm going to end there because we don't have any time. But you just have to keep that in mind that with earthquakes and then bombing man-made awful things like machine gunning 500 people in Las Vegas, that's a high ratio of injured and big taxation on the healthcare system. And then the bombing from earthquakes, you have a big taxation in regard to needs, you lose half of your resources. So that's the real problem. So questions or comments? Don't want to go home? I worked for 3 last night. I didn't have to.